Hi, I'm Dr. Mike McInnes. I'm one of the chief educators at Doctors in Training, and I want to welcome you to the Solid Anatomy Introduction Part 4 lecture. In this video, we'll be covering the basics of the nervous system, including the somatic nervous system and the autonomic nervous system, which includes the parasympathetic and sympathetic nervous systems. Very important stuff. I'll be back later with some clinical correlations and for the end of session quiz, but for now, I'm going to hand it over to our primary lecturer, Dr. John Phelan.
As you proceed through your human anatomy course, you will memorize the name of the nerves that innervate each of the skeletal muscles in the body. Variation in innervation is rare. For instance, the biceps brachii muscle is nearly without exception innervated by the musculocutaneous nerve in every human being. If you are dissecting a cadaver during your anatomy course, you will notice that nerves usually enter the deep side of the fleshy or non-tendinous portion of the muscle. Blood supply to muscles is more variable than nerve supply and usually derives from multiple sources. Our nervous system controls voluntary actions, which may be actions across joints like waving, or actions not involving joints, like winking. It also controls involuntary actions, like the constriction of the pupils, or peristalsis of the gut. Thus, we say the nervous system may be functionally divided into a voluntary, or somatic, nervous system, and an involuntary, or autonomic, nervous system. Perhaps you've noticed that some components of the nervous system, like the brain and the spinal cord, are housed within the bones of the skull and the spine, or vertebral column, while others, like the nerves running through the arms and legs, are not. Therefore, the nervous system may be structurally divided into the central nervous system and the peripheral nervous system. All nervous tissue is made up of two types of cells, neurons and glia, or neuroglia. Glia are involved in the structural and metabolic support of the neurons, which are the cells involved in transmitting nervous signals. The neuron, commonly referred to as a nerve cell, is the basic functional unit of the nervous system. A typical neuron consists of a cell body, which contains the nucleus of the nerve cell, and its processes, which are usually a single axon and multiple dendrites. A dendrite of one neuron receives information transmitted by the axon of another neuron at specialized junctions between these processes called synapses. A single axon covered by glial cells and by connective tissue that separates it from other axons is referred to as a nerve fiber. In the central nervous system, a collection of cell bodies is called a nucleus, not to be confused with the nucleus of a cell. And a collection of nerve fibers is called a tract. In a cross-section of the brain, one may observe concentrated areas that are gray amidst a preponderance of white tissue. The gray areas are referred to as gray matter, which are collections of neuronal cell bodies that form nuclei. The white areas are called white matter and consist of nerve fibers that form tracts. Most of the brain is made up of nerve fibers. Concentrated areas of nerve fibers appear white because many axons are covered by insulating sheaths of myelin, a white fatty substance manufactured by glia that increases the speed of signal propagation. In cross-section, the spinal cord has a central butterfly-shaped or H-shaped area of gray matter surrounded by white matter. The gray matter is arranged in a pair of ventral horns and a pair of dorsal horns. The cell bodies in the ventral horns belong to neurons involved in motor innervation, while those in the dorsal horns belong to neurons involved in sensory innervation. 3 layers of connective tissue membranes called the meninges cover the central nervous system. The cranial meninges cover the brain. The spinal meninges cover the spinal cord and nervous structures extending from it. They protect and nourish the nervous tissue that they surround. From superficial to deep, the meninges are the dura mater, the arachnoid mater, and the pia mater. The tough, fibrous, inelastic outer layer, the dura mater, is bilaminar in the cranium and separates to form venous channels. The spinal dura mater is unilaminar and forms the dural sac within the vertebral canal, which ends in the lumbar cistern, which is a popular site for sampling cerebrospinal fluid by lumbar puncture because the spinal cord ends superior to it and therefore is not in danger of being damaged by an invading hypodermic needle. The spinal dura mater extends laterally to surround the dorsal and ventral roots and ends at the intervertebral foramina by blending in with the periosteum of the vertebrae and with the connective tissue covering of the spinal nerves as they exit the vertebral column. Between the dural sac and the walls of the vertebral canal is the epidural space, which contains epidural fat and the internal venous plexus. The arachnoid mater is a delicate, web-like, diffuse, avascular, fibrous and elastic membrane that loosely invests the brain and spinal cord. The space between the arachnoid mater and the pia mater, the subarachnoid space, contains cerebrospinal fluid that is manufactured in the brain. The pia mater is very thin and elastic and adherent to the brain and spinal cord, as well as to the roots and spinal nerves. The spinal pia mater has extensions forming ligamentous structures that suspend the spinal cord within the dural sac and anchor it in place, preventing its displacement during movement of the vertebral column.
Welcome back. Let's take a moment to talk about the LP, or lumbar puncture, also known as a spinal tap. A common test question is, what level should the needle for a lumbar puncture be inserted? An LP is performed by inserting a needle between L3 and L4, or between L4 and L5. Then the next natural question is normally, how do I identify where L4 is? Well, the best landmark is to use the patient's hips. So you use the highest point of the iliac crest. Basically, you find the highest point of the iliac crest, and then at this level you draw a horizontal line medially from the iliac crest directly to the spine, and that's where L4 is. An LP can be done with the patient lying on their side in the fetal position, like in the image here, or with the patient sitting upright on the bed. Now, locating the iliac crest is a commonly overlooked step. When you perform an LP, you have to identify this before you go in with a needle because it's often higher than you think, and it may take some effort to locate this landmark with obese patients. Now, just FYI, as another clinical pearl for you, once you've identified the site, you want to mark the puncture site so you have a target. But since you're going to clean and sterilize the patient's skin before you insert the needle, if you mark it with a pen, the pen mark's going to be washed off. So what you can do is take your fingernail and mark the spot by leaving an impression. Or you can make an impression with a retractable pen. You retract the stylus of the pen. There's no ink, but the tip of the pen will leave a little circle. This way, when you wash off the skin, that circle impression is still there. It's going to be there for a good 5 or 10 minutes. So you just aim your needle for the center of that circle. Another common test question is, what ligament must be punctured in order to successfully perform an LP? So the needle has to go through the ligamentum flavum. You feel a resistance at first when inserting the needle while going through that ligament, and then you're going to feel a sensation of a release as the needle makes it through the entire ligament. So that's it for lumbar punctures.
In the peripheral nervous system, a collection of cell bodies is called a ganglion, and a bundle of nerve fibers is called a nerve. Peripheral nerves are covered by connective tissue that imparts strength and resiliency. The endoneurium covers individual nerve fibers. The perineurium covers bundles of nerve fibers, or fascicles. And the epineurium surrounds the entire nerve, as well as the blood and lymphatic vessels supplying the nerve. A peripheral nerve that relays information from the periphery to the central nervous system is said to be afferent or sensory, while a peripheral nerve that relays information from the central nervous system to the periphery is said to be efferent or motor. The mnemonic SAME, S-A-M-E, may be helpful in remembering that sensory nerves are referred to as afferents, while motor nerves are referred to as efferents. The two types of peripheral nerves are cranial nerves and spinal nerves. Most of the 12 pairs of cranial nerves originate or terminate in the gray matter of the brainstem at collections of neuronal cell bodies called nuclei. The exceptions are the first and second cranial nerves, which are extensions of the forebrain, and the 11th cranial nerve, which is a branch of the spinal cord that enters the cranium. All of the cranial nerves pass through openings in the cranium. The cranial nerves carry motor or sensory fibers, or fibers carrying sensations of taste, smell, sight, and sound, or some combination of those fibers. 4 cranial nerves also carry parasympathetic fibers, which will be described shortly. The 31 pairs of spinal nerves emerge from the spinal cord and pass through openings in the vertebral column or spine. Spinal nerves are formed from a ventral root, which carries axons of motor neurons out of the spinal cord, and a dorsal root, which carries axons of sensory neurons into the spinal cord. The two roots unite distal to a dorsal root ganglion to form a spinal nerve. Each bilateral pair of spinal nerves arises from a spinal cord segment, which is a section of the spinal cord giving rise to all of the nerve fibers that ultimately combine to form that pair of spinal nerves. A spinal nerve is a mixed nerve containing motor and sensory fibers. Upon leaving the vertebral canal, it immediately divides into dorsal and ventral primary rami, both of which are also mixed nerves. The dorsal primary rami provide motor innervation to axial muscles or intrinsic back muscles. These are muscles that act only on the head and vertebral column, as opposed to appendicular muscles which act on the limbs. Appendicular muscles receive their motor innervation from ventral primary rami. Sensation to skin on the posterior side of the head, neck, and trunk of the body is provided by dorsal primary rami, while skin on the anterior side of the body and on the limbs receives sensory innervation via the ventral primary rami. A myotome is the collection of muscles receiving motor innervation from a single spinal nerve, while a dermatome is the area of skin receiving sensory innervation by a single spinal nerve. Myotomes and dermatomes tend to be approximations, and usually there is significant overlap between myotomes and dermatomes of adjacent spinal nerves. Myotomes and dermatomes of the trunk of the body are generally segmentally arranged from superior to inferior. However, the ventral rami supplying the appendages combine to form plexuses which yield a series of nerves that receive contributions from multiple spinal nerves. The myotomal and dermatomal pattern of the limbs is consequently more complicated than that of the trunk.
Welcome back. We're talking about the dermatomal map, so how does this relate clinically? The pattern of the sensory spinal nerves and the corresponding dermatome map is important when it comes to the diagnosis and management of herpes zoster, which you may know by the name shingles. So when you're first infected with varicella zoster virus, you get an infection called varicella or chickenpox. Then the chickenpox goes away after a week or so. Then the reactivation of the disease is called herpes zoster or shingles. Now with herpes zoster, the varicella zoster virus becomes latent in the dorsal ganglia after primary infection. When the virus reactivates, you usually see a very painful rash in a classic pattern. Grouped vesicles on an erythematous or red base occurring in a single dermatome, which corresponds to whatever dorsal root ganglion the virus was living in. So, if you ever see a rash that's unilateral in a single dermatome, you should absolutely consider herpes zoster for your diagnosis. However, if that rash crosses the midline, it's usually not shingles. Shingles usually stays in a single dermatome and does not cross the midline. The problem with diagnosing herpes zoster is that sometimes the dermatomal pain precedes the rash. So say you have a scenario like this. A patient comes in complaining of intense chest pain and you work them up for all kinds of chest pain diagnoses. Or maybe they have abdominal pain and you're working them up for gallbladder disease or acute appendicitis or whatever. Then after all the EKGs and chest x-rays and CTs and labs, your patient finally develops that characteristic unilateral rash of grouped vesicles in this dermatomal pattern 2 or 3 days later, and then you have your diagnosis. Now, one trick is that even before the rash appears, you could try lightly touching the skin over the area where they have pain, because these patients can have pain with just very light touch of the dermatome. The term for this is allodynia. You can also ask the patient about the character of the pain. Most patients describe shingles pain as a burning or throbbing pain. All right, let's go ahead and pick back up and talk about the somatic nervous system.
As mentioned previously, the nervous system may be functionally divided into the somatic nervous system and the autonomic nervous system. The somatic nervous system innervates structures that are derived from the somites in the embryo, such as the muscles and the skin, while the autonomic or visceral nervous system innervates structures not derived from the somites, such as the viscera, meaning the internal organs, and the glands. Peripheral nerves may thus be categorized as somatic efferent, somatic afferent, visceral efferent, and visceral afferent. Somatic efferent nerve fibers provide motor innervation to skeletal muscle, while somatic afferents provide pain, touch, and temperature sensation from skin. Visceral efferents are motor neurons to smooth muscle, cardiac muscle, and glands. Visceral afferent fibers provide stretch and pain sensation from organs. The somatic efferent, or motor component of the nervous system, begins with upper motor neurons whose cell bodies are found in the brain. Their axons descend through the brain and into the spinal cord through tracts in the white matter. The axons terminate in the anterior horn of the gray matter of the spinal cord by forming synapses with lower motor neurons. Thus, cell bodies found in the anterior horn of the gray matter of the spinal cord belong to lower motor neurons. The axons of the lower motor neurons leave the spinal cord via ventral roots, travel through the spinal nerves, and then run in the ventral and dorsal rami to reach their target muscles. The preganglionic axons of visceral efferent neurons also leave the spinal cord via the ventral roots, and will be discussed in a moment. Somatic nerves are made up of the axons of pseudounipolar neurons. This type of neuron has axons that bifurcate into central and peripheral processes. These sensory pseudounipolar neurons are referred to as primary neurons. Their peripheral processes begin in the target from which the sensory information is received, such as the skin. Their cell bodies are found in a dorsal root ganglion, which is located within a dorsal root at the level of the intervertebral foramina. Their central processes pass through dorsal roots to enter the spinal cord and synapse in the dorsal horn of the gray matter with secondary neurons. The axons of the secondary neurons ascend in tracts of the white matter, ultimately synapsing with tertiary neurons in the brain. Note that there are no synapses in the dorsal root ganglia. A rule to memorize is that sensory ganglia, that is, collections of cell bodies of sensory neurons in the peripheral nervous system, have no synapses. Parasympathetic ganglia, which will be mentioned again in a moment, do contain synapses. The visceral or autonomic nervous system may be divided into a sympathetic and parasympathetic system. Let's start with a description of the sympathetic system. As we've already described, the gray matter of the spinal cord forms ventral horns, which are the locations of the cell bodies of the lower motor neurons, and dorsal horns, which are the locations of the cell bodies with which the peripheral sensory neurons arriving through the dorsal roots synapse. Along the thoracic levels of the spinal cord and into the first and sometimes second lumbar level, there is also a lateral horn of the gray matter, where the cell bodies of presynaptic sympathetic efferent nerve fibers are found. The sympathetic nervous system is characterized as thoracolumbar due to this origin. The preganglionic, a term synonymous with presynaptic, sympathetic efferent nerve fibers, or visceral efferents, leave the lateral horn of the gray matter via the ventral roots, which join with the dorsal roots to form spinal nerves. The sympathetic fibers leave the vertebral column through the intervertebral foramina with the spinal nerves. When the spinal nerves bifurcate into ventral and dorsal rami, the sympathetic nerves follow the ventral rami peripherally. The sympathetic fibers leave the ventral rami to join the sympathetic trunks by passing through connections called white rami communicans. The bilateral sympathetic trunks run vertically along the posterior thoracic wall, lateral to the vertebral column. The sympathetic trunks have paravertebral ganglia at each level, where the cell bodies of the postsynaptic sympathetic fibers are located. The sympathetic trunks extend superiorly into the neck and inferiorly into the abdomen and the pelvis. Once a preganglionic sympathetic efferent fiber reaches the sympathetic trunk, it may follow one of three courses. If the target organ is in the head, such as the dilator pupillae muscle, a muscle of the eyeball involved in dilation of the pupil, the sympathetic fiber will ascend through the cervical sympathetic trunk in the neck. The sympathetic fiber will synapse at the superior cervical ganglion, which is the site of the cell bodies of all postganglionic sympathetic fibers destined for target organs in the head. The superior cervical ganglion, which is usually longer than the other ganglia in the sympathetic trunk, is located at the level of the second and third cervical vertebrae. The postganglionic sympathetic nerves then follow the carotid arteries and their branches into the head to reach their target organ. If the target organ is a blood vessel, erector muscle of a hair follicle, or a sweat gland in the trunk or the limbs, the sympathetic fiber will ascend or descend, or stay at the same level of the sympathetic trunk to reach the appropriate level according to the location of the target organ. It will synapse at one of the paravertebral ganglia found along the sympathetic chain. Postsynaptic sympathetics then pass through a gray ramus communicans, which connect the sympathetic trunks to the ventral rami. The postsynaptic sympathetics follow the ventral ramus to the target organ. Sympathetics are involved in vasomotion, pilomotion, and pseudomotion. Specifically, these actions are contraction of the smooth muscles of the blood vessels, or vasoconstriction, erection of the hair follicles, resulting in goosebumps, and stimulation of the sweat glands, resulting in sweating. If the target organ is part of the abdominal viscera, the sympathetic fiber will descend the sympathetic trunk without synapsing and continue through an abdominopelvic splanchnic nerve. These are the greater, lesser, and least splanchnic nerves, which carry preganglionic sympathetic fibers from spinal cord levels 5 through 9, 10 and 11, and 12, respectively. The splanchnic nerves leave the sympathetic trunk and run inferomedially. They pass under the diaphragm to reach the abdomen and synapse at the prevertebral ganglia associated with the abdominal aorta. Postganglionic fibers follow the arteries to reach their target organs. The exception to this pathway is the adrenal gland. The parasympathetic nervous system is described as craniosacral because the cell bodies of presynaptic, parasympathetic, efferent neurons are found in nuclei in the brainstem and in the gray matter of sacral segments of the spinal cord. The cranial parasympathetics leave the brain with the 3rd, 7th, 9th, and 10th cranial nerves. Those traveling with the first 3 of those cranial nerves synapse at one of 4 parasympathetic ganglia in the head, and the postganglionic parasympathetics follow other cranial nerve branches to reach their target organs, such as the salivary glands and the muscle that constricts the pupil in the eyeball. The parasympathetics that are associated with the 3rd, 7th, and 9th cranial nerves only act on targets in the head. However, the 10th cranial nerve, which is called the vagus nerve, passes through the neck, the thorax, and into the abdomen. The preganglionic parasympathetics traveling with it are distributed to viscera in all of these regions, including the laryngeal apparatus in the neck, the heart in the thorax, and most of the gastrointestinal tract in the abdomen. These parasympathetics synapse at ganglia found on the surface of or embedded in their target organs, so their postganglionic fibers are very short, while their preganglionic fibers are long. The sacral parasympathetics leave the spinal cord through the ventral roots of spinal cord levels S2, S3, and S4, and then branch from these roots in the pelvis as the pelvic splanchnic nerves, which are still preganglionic. These pelvic splanchnic nerves provide preganglionic parasympathetic innervation to the lower portion of the gastrointestinal tract and to the pelvic viscera, such as the uterus. Their ganglia are also found on or embedded in their target organs. The story of visceral afferents is rather complex and varied. Some visceral afferents are pseudo-unipolar neurons whose peripheral processes start at their target organ and then follow the sympathetic visceral efferents backwards to the sympathetic trunk and then to the spinal nerve. The cell bodies of these afferents, like those of the somatic afferents, are in the dorsal root ganglia. Their central processes follow the dorsal root back to the dorsal horn of the gray matter in the spinal cord, where they synapse. Other pseudo-unipolar visceral afferents follow the vagus nerve backwards from their target organ. These afferents have cell bodies in the inferior nodose ganglion of the vagus near the opening of the skull that the vagus passes through. Their central processes enter the brain stem and synapse at the nucleus of the solitary tract. Still other visceral afferents, the ones below the pelvic pain line, which is located at about the inferior level of the peritoneum, follow the sacral parasympathetic efferents back to the spinal cord.
So that's the last introductory lecture. Now it's time for the end of session quiz. So pause the video and answer the end of session quiz questions in your study guide, then restart the video and we'll go through those answers together. Let's get started. First, what types of cells make up nervous tissue? So you have neurons and also glia. Next, what are the layers of the meninges? So you have the dura mater, the arachnoid mater, and the pia mater. Next, which two cranial nerves are extensions of the forebrain? These are cranial nerves 1 and 2. Next, how many spinal nerves are there? So there are 31 paired nerves, so that's a total of 62 spinal nerves altogether. Next, where do appendicular muscles receive motor innervation? This is the ventral primary rami. Next, what are examples of structures innervated by the somatic nervous system? Remember, these are structures derived from the somites, such as skin and muscles. Next, what are examples of structures innervated by the autonomic nervous system? These are structures not derived from the somites, like the visceral organs and the glands. Next, characterize the following as sympathetic or parasympathetic. Craniosacral is parasympathetic, and then thoracolumbar is sympathetic. All right, we're almost done. We've also provided some images for you to label. Being able to identify structures in a time setting will help you prepare for your lab practical. So label the images and we'll be finished.